Hi guys, so for today's video, I want to go over the cardiovascular examination again because the first one I did, it was quite rushed and I didn't put enough detail as I wanted to. So I just want to redo the whole thing. So let's get started. So when you're doing a cardiovascular exam, the first thing that you need to assess or the first thing you need to do is a general inspection of the patient. So you just look at the patient as they come into the examination room. So you look at things like anything that would give clues about their cardiovascular health. So their weight, are they obese? If you could see their peripheries, their limbs, you could see if there are any signs of edema. You could also see the patient if they're in distress or in any sort of anxiety or pain. If they're clutching their chest, that suggests that they have chest pain. So that's the first thing that we need to do. The second thing that we need to assess is the patient's blood pressure. So when we're taking the patient's blood pressure, we need to do this in a quiet room, preferably a room with very minimal noise and minimal distractions. And we need to let the patient rest for at least 5 minutes, because they might have just ran to the consultation room, so this would skew the results. So we need to let them rest or sit down for a bit for at least 5 minutes. And then we need to select the correct size cuff for the patient. We need to make sure that the bladder of the cuff is centered over the brachial artery in an unclothed arm. So it has to be unclothed. If there's clothing there, you could roll it up or ask the patient to take the jumper off or something. And you have to position the arm around about heart level, so around about the fourth intercostal space, because if you take the blood pressure on an elevated arm, then that would show lower readings. And the opposite is true. So if you drop the arm and you take the blood pressure like this, so if it's below heart level, then it might just show higher blood pressure results. So that's really important. Rest it, but make sure that it's around about heart level. So what we actually do is we inflate the cuff, and we inflate it to the point where it's about 30 millimeters of mercury above the point where the brachial or the radial artery disappears. And then we need to deflate the cuff slowly and listen for the first carotid cough sounds, which marks the systolic blood pressure. And then we continue deflating the cuff until we hear the last few carotid cough sounds, and these mark the diastolic blood pressure. The third thing that we need to assess is the patient's heart rate. So with heart rate, you could do it in multiple ways. So you can either palpate the radial artery and count number of beats per 15 seconds and multiply that by 4, so you get the number in a minute. Or you can auscultate the PMI, so that's at the fifth intercostal space, mid-clavicular at the left side, auscultate that point and with your stethoscope, and then just count the number of heartbeats you hear in 15 seconds, and again multiply that by 4, and then you can get the patient's heart rate. The fourth thing that we need to do is measure the patient's Jvp. So the Jvp is measured at a vertical distance above the sternal angle, or the angle of Louis. So this is that bony ridge that you can feel where the manubrium joins with the sternum. So the measured Jvp that is greater than 3 centimeters above the sternal angle, or greater than 8 centimeters if measured above the right atrium, is considered elevated or abnormal. The Jvp provides us with an indirect measure of the pressure in the right atrium. So this is usually assessed by looking at the right internal jugular vein pulsations, which is actually quite tricky to find because the right internal jugular vein runs underneath the sternocleidomastoid, and the right external jugular vein runs parallel to the right internal jugular vein. And in fact, the right external jugular vein is a lot easier to find and to visualize, which again makes it tricky. But we don't commonly use the right external jugular vein to measure Jvp. Because the right external jugular vein has more valves and has a more indirect route to the right atrium, whereas the right internal jugular vein literally sits directly above the right atrium. So we commonly use the right internal jugular vein as opposed to the right external jugular vein. So to measure the JVP, we need to ask the patient to lie supine. We need to elevate the head of the bed to about 30 degrees in angle. And then we need to ask the patient to turn their head away from the side that we're examining. So if we're examining the right side of the neck, we need to ask the patient to turn their head to the left side and vice versa. So we need to examine both sides, and we need to look for the external jugular vein on both sides and locate the internal jugular vein pulsations. And then we turn our attention to the right internal jugular vein. So this might be difficult to find. So to help us, we can use something called tangential lighting. So it's basically shining like a light, like a pen light, directly, like diagonally across the patient's neck to help us visualize the pulsations. So for instance, this is like the surface of the patient's neck. We just shine it diagonally to the patient's neck. And that would help us identify the internal jugular vein pulsations. Once we've identified the highest point of oscillation, what we need to do is we need to extend a rectangular object with a straight edge horizontally from this point. So I'm just gonna try demo, but this is not gonna be perfect, obviously, because I can't see what I'm doing. And you need to put a ruler vertically from the above the sternal angle. So find the highest point of oscillation, extend a straight edge or a rectangular object horizontally from that point, and you need to put a ruler vertically from the sternal angle. And then, can you see that? Where they cross, you measure the vertical distance from the sternal angle. So that's where the ruler and the other ruler cross. I don't know if you can see. So let's just pretend that it was 2 centimeters. You need to measure it in centimeters, by the way. So then it's 2 centimeters. So that's normal, because the normal measurement of JVP above the sternal angle is under 3 centimeters. We could add 5 centimeters to this number to calculate the JVP from the right atrium. So for example, mine was 2, I add 5, so that's 7. So the normal, if calculated above the right atrium, is under 8 centimeters. So actually what you get, so the first measurement that you get above the sternal angle plus 5 cm, the sum of those two numbers is the JVP. And again, the normal value is under 8 centimeters. Sometimes it may be necessary to adjust the head of the bed. So we started with 30 degrees. So it depends on the fluid condition of the patient. So for instance, if our patient has hypovolemia, or like, for example, our patient is septic, then we expect the JVP to be low. So in this case, what we need to do is to lower the head end of the bed, sometimes to even about 0 degrees, so the patient lies completely flat for us to be able to visualize the highest point of oscillation better. The opposite is true. So if we have a patient who has fluid overload or is hypervolemic, then we expect the JVP to be higher. So what we need to do is we need to adjust the head of the bed higher. So we need to put it to about 60 degrees or sometimes even 90 degrees for us to be able to visualize the highest point of oscillation the best. So we need to be able to distinguish the JVP pulsations from the carotid pulsations. So with JVP pulsations, it's actually non-palpable, whereas the carotid, obviously we could palpate this and we can feel the carotid artery pulse. With JVP as well, it's a biphasic waveform, so we get 2 pulses per heartbeat, whereas in the carotid pulse, there's only one beat, 1 pulse per heartbeat. The height of the JVP, the height of the oscillation point for the JVP can be changed with positions. So if we put our patient more upright, the JVP, the point of oscillation, actually drops, whereas the carotid pulsations would be not affected by the change in the position of the patient. Also with JVP, the height of the pulsations would be altered by inspiration and expiration. So in inspiration, JVP would actually fall due to the decrease in intrathoracic pressure, which creates like a sucking effect on venous return. Whereas in carotid pulsations, they would be not affected by the respiration. And finally, for the JVP, if we press on the liver at the right upper quadrant, we can see a transient increase in the JVP, and this is called the hepatojugular reflex. The carotid pulse, again, would not be affected by the hepatojugular reflex. Elevated JVP. So if our JVP is over 8 centimeters or more than 3 centimeters when calculated above the sternal angle, is correlated to certain diseases like a superior vena cava obstruction, chronic pulmonary hypertension, cardiac tamponade, constrictive pericarditis, and heart failure due to the fluid overload. So now let's talk about the Jvp waveforms. So these specific waves are created by the oscillations in the internal jugular vein, and these oscillations reflect the change in pressure in the right atrium. So in the waveforms, there's two main peaks and two main troughs. So the peaks, we have the A wave and we have the V wave, and for the troughs we have the X descent and the Y descent. So I'm gonna show you now what that looks like. So we have the A wave, and then we have another mini peak, the C wave, and then the whole thing is the X descent, and then the second main peak is the V wave, followed by the Y descent. Okay, so I'm going to do this now. Right. So hopefully you have that picture in your mind. If not, just Google it up. So the A wave is the first main peak in the Jvp waveforms. So this happens just before S1, which means it happens before the carotid upstroke. So this happens during atrial contraction. So during atrial contraction, the pressure in the right atrium increases as it attempts to push blood to the right ventricle. And as it pushes blood to the right ventricle, there's also some pressure exerted upwards, up to the vena cava, and therefore up to the internal jugular vein, which explains why we see a rise in the jugular venous pressure. So our A wave is followed by the first X descent. So the X descent happens during atrial relaxation. So during atrial relaxation, the pressure in the atria, the right atrium, falls as the blood just flows into the right ventricle. This is then followed by a mini peak we call the C wave. So the C wave happens during the start of ventricular contraction. So during the start of ventricular contraction, what happens is the right ventricle obviously pushes blood to the pulmonary arteries, but as it does that, it also exerts pressure back up to the tricuspid valve, causing that tricuspid valve to slightly bulge into the right atrium. And as it bulges into the right atrium, obviously that pressure then extends to the vena cava and therefore up in the internal jugular vein. So the second X descent happens at the end of ventricular contraction. It's at that point when the ventricle, the right ventricle, is so small, it then, because it's just squeezed blood to the pulmonary artery, so it's smaller, creating more space in the pericardium for that right atrium to actually fill with blood. So in a way, this kind of acts like a vacuum. So with the right ventricle shrinking in size, it allows the right atrium to expand more, to fill more with blood. That's why we see this the second X descent. The second X descent is followed by the V wave. So the V wave is due to the venous filling, so the filling of the right atrium. So at this point, the tricuspid valve is still closed. So when the right atrium starts to fill with blood, as it completely fills with blood, the filling extends up to the vena cava and therefore up to the internal jugular vein, which is why we see that peak, that increase in jugular venous pressure. And then this is followed by the Y descent. So the Y descent happens when that tricuspid valve finally opens, allowing the blood in the right atrium to just flow into the right ventricle. So obviously this reduces the pressure in the right atrium and therefore reduces the pressure in the vena cava and reduces the pressure in the internal jugular vein, and therefore we see a fall in the JVP. Okay, so I know that is quite a lot, so let's try just simplify everything and just summarize everything about the Jvp waveforms. So we have the first peak. So we have the A wave. So the A wave is for atrial contraction, and that the atrial contraction means higher pressure in the atrium, which is why we see that peak. This is followed by the X descent. So X descent, the first one is it happens during atrial relaxation. This is then followed by a mini peak, the C wave, and the C wave happens at the start of ventricular contraction, and that pushes to the tricuspid valve, exerting some pressure back up to the right atrium and back up to the vena cava and back up to the internal jugular vein, which is why we see that little bit of increase in the JVP. And this is followed by the second X descent. So the second X descent it happens at the end of ventricular contraction when the right ventricle is so small, acting like a vacuum for the right atrium to fill with more blood. Therefore, the pressure in the right atrium decreases, which is why we see the X descent. And then this is followed by the second main peak, which is the V wave. So the V wave happens during the venous filling, so the filling of the right atrium when the tricuspid valve is still closed. And the final descent, the Y descent, happens when the tricuspid valve finally opens and the pressure in the right atrium decreases as the blood just flows into the right ventricle. So just to mention some of the abnormalities that we may see in these waveforms. So we might have absent A waves. So absent A waves is usually indicative of atrial fibrillation. And if you get prominent A waves, so the opposite of absent, more prominent A waves, this usually happens when there's increased resistance in atrial contraction. So for instance, this may happen if we have tricuspid stenosis or pulmonary hypertension. Finally, increased V waves may be indicative of tricuspid regurgitation or atrial septal defects and even constrictive pericarditis. So once we finish with the JVP measurements and assessment, we move on to assessing the carotid pulse. So the carotid pulse, we assess for the different characteristics of the pulse. So we assess for the amplitude, the contour, the presence of thrills or bruits. So we do this by asking the patient to lie supine, again with head slightly elevated up to 30 degrees. We palpate. Sometimes we could actually see the carotid pulsations. It's medial to the sternocleidomastoid, but we still have to palpate the carotid pulse so that we can assess this. We use our index and middle finger to palpate the carotid pulse. We usually just palpate the right side or just one side. You'd never palpate both carotid arteries at the same time because that would definitely decrease blood flow to the brain and may induce syncope. The amplitude of the carotid pulse correlates well with the pulse pressure. So if the amplitude is weak or thready or small, then this might be indicative of a cardiogenic shock. If the opposite is true, so if for example the amplitude is bounding, then this might be indicative of aortic regurgitation. We also need to assess the contour of the pulse. So for contour, we need to assess the speed of the upstroke, the duration of the summit, and the speed of the downstroke. So the upstroke is usually brisk, the summit is rounded and smooth, and the downstroke is usually less brisk than the upstroke. Now let's discuss some of the variations or some of the abnormalities that we may see when we're assessing the carotid pulse. So, for instance, the amplitude of the pulse may vary from beat to beat. So, this is called pulsus alternans. So, in pulsus alternans, the rhythm of the pulse remains regular, but the force of the pulse alternates between weak and strong due to the alternating weak and strong contractions of the left ventricle. And this is usually indicative of severe left ventricular heart failure. So this happens in severe left ventricular heart failure because in left ventricular heart failure, the left ventricle is not powerful enough to pump as much blood out into the aorta. This means that in that specific cycle, the blood pumped out, the volume is very low, and therefore we generate a weak pulse. But this also means that for the next contraction, because only a small amount of blood is pumped out of the left ventricle, it means that there's more blood that's left in the left ventricle for the next cycle. So the more blood that's left in the left ventricle means more stretching of the myocardium. And this is actually Frank Starling law that I'm describing. So if there's more blood left in the left ventricle, there's more stretching in the left ventricle, there's more powerful contraction in the left ventricle for the next cycle. So this then gives rise to a strong pulse, and the cycle just continues over and over again with weak pulse and then strong pulse, and just alternating weak, strong pulse, and then we get pulsus alternans. So the next variation in pulse, or the next abnormal pulse that we may see or feel, is called pulsus paradoxus. So pulsus paradoxus happens when the amplitude of the pulse varies with respiration. So usually when we inspire, the systolic blood pressure decreases due to the decrease in intrathoracic pressure. But usually this decrease in systolic blood pressure, the magnitude is very, very small, like less than 10 millimeters of mercury, and it's not appreciated by palpation really. But what happens in pulsus paradoxus is there's a more marked decrease in systolic blood pressure. So usually it's greater than 10 millimeters of mercury, and this is therefore detectable by palpation. But we need to verify this with a sphygmomanometer just to double check that the decrease is actually greater than 10 millimeters of mercury, because that's the the characteristic, that's the criteria for this to be called pulsus paradoxus. So if pulsus paradoxus is present in a patient, we need to immediately suspect cardiac tamponade. But this can also happen in other conditions like constrictive pericarditis, or if our patient has hyperinflammatory lung conditions or obstructive pulmonary diseases like asthma or COPD. The next variation, or the next abnormality, is pulsus bispherians. So bis means two. So this is actually also called a biphasic pulse. So in pulsus bispherians, what we have is it's an aortic waveform with two peaks in systole, so 2 peaks per cardiac cycle. The next abnormality is pulsus parvus et tardus. So this is characteristic of aortic stenosis. So in pulsus parvus et tardus, my god, these Latin words. So in pulsus parvus et tardus, we have a slow rising weak pulse. So pulsus tardus, tardus means late. So this gives us that delayed peak and slow rising upstroke. And pulsus parvus, I assume, means small amplitude pulse, which gives us that weak pulse. So if we combine those together, we get pulsus parvus et tardus, which means slow rising pulse, so slow rising upstroke with a weak pulse. So after assessing the amplitude and the contour of the carotid pulse, we can then move on to assess if there are any thrills or bruits. So we can palpate the carotid pulse and feel for any vibrations called thrills. We can then auscultate the carotid arteries for any bruits. So bruits are just murmur-like sounds that are generated due to turbulent blood flow in the arteries. If for any reason we cannot assess the carotid pulse. For example, if the patient has carotid obstruction, kinking, or like thrills in the carotid arteries, it's probably best not to not to fiddle with the carotid arteries. We can use the brachial artery as a substitute. So we apply the same techniques, same methods. We assess for the same things. We assess for the amplitude and the contour of the pulse. And with brachial, you need to have the arm extended with palm facing up. And you need to use your index and middle finger to palpate the brachial artery. So just a quick recap so far. So far we've done general inspection of the patient, we've done blood pressure, we've done heart rate, we've done the JVP, we've done the carotid pulse or the brachial pulse, and now we need to move on to the main star of the show, the heart. So when examining the heart or when assessing the heart, we follow the same sequence of examination as the other body systems. So we do inspection, palpation, percussion, and then auscultation. So we start with the inspection of the heart. So we inspect just the general chest area where the heart is located. So we look for any deformities, any scars from previous surgeries, any lesions, any ecchymosis, and any visible pulsations that we may see. And then we move on to palpation. So we need to palpate for heaves and lifts. So heaves and lifts are sustained impulses that rhythmically lift your fingers. So these are usually caused by enlarged ventricles or atria. So what you do simply to feel for heaves and lifts is to palpate the chest with flat fingers. So you just do that and feel for these rhythmic impulses. The second thing that we need to palpate for are thrills. So thrills are just palpable murmurs. So these are usually generated due to the turbulent blood flow through a vessel or a valve. And they are so marked that they produce palpable vibrations. So if thrills are present, we need to use our stethoscope and we need to auscultate that same area where we feel the thrills to listen for the murmurs. The third thing that we need to palpate for is the PMI, or the point of maximal impulse. So we need to assess the location of the PMI, the diameter, the amplitude, and the duration. So location, so typically the PMI is located where the apex of the heart is located. So that's the fifth intercostal space, mid-clavicular on the left side of the chest. But there are some special cases. So for instance, in patients with dextrocardia, so this is a rare congenital transposition of the heart, meaning that the heart is actually on the right side of the chest cavity. Therefore, this generates a right-sided impulse. Actually, it's the same case with patients with situs inversus. So in situs inversus, organs like the heart, the stomach, and the spleen, which are usually on the left side, are on the right side of the body. So that again generates right-sided apical impulse. Also, a more common example is in pregnancy. So in pregnancy, the diaphragm of the mother is pushed up because of the uterus, So this may shift the apical impulse upwards. Also, the PMI may be displaced laterally towards the axillary line in cases where there is ventricular dilation. So for instance, in the case of heart failure. Also, if there are any injuries that lead to thoracic deformities and mediastinal shift, then the PMI may be in a different location as well. The second characteristic of the PMI that we need to assess is the diameter. So if the patient is lying supine, the diameter of the PMI can be as large as 1 to 2.5 centimeters in diameter. If it's larger than 3 centimeters, then this generally points towards left ventricular hypertrophy. Also, if you roll the patient into the left lateral decubitus position, the PMI may feel larger. But again, the same rule applies. If it's bigger than 3, if the diameter of the PMI is bigger than 3 centimeters, then this is indicative of left ventricular hypertrophy. And if it's greater than 4 centimeters, then this is indicative of a severe left ventricular overload. The next characteristic is the amplitude. So the amplitude of the PMI is usually small, brisk, and tapping. So in young adults, we may have like a higher amplitude impulse called a hyperkinetic impulse, especially when the young adults are excited or after they've just exercised. However, a hyperkinetic impulse may be pathological as well. So this can be seen, for example, in patients with severe anemia or patients who are hyperthyroid. Finally, the last characteristic of the PMI that we need to assess is its duration. So to do this, we need to listen to the heart sounds as we palpate the apical impulse. And we need to estimate the proportion of systole that is occupied by the apical impulse. This usually lasts through the first 2/3 of systole, but does not usually continue through the second heart sound. So if we cannot locate the PMI when the patient is lying in a supine position, what we can do is to roll them into the left lateral decubitus position, because if we do that, this position brings the apex of the heart closer to the chest wall of the patient. After palpating the PMI, we can then move on to palpate the right ventricular area, which is at the 3rd, 4th, and 5th intercostal spaces, left parasternal border. And we could also palpate the pulmonic and the aortic valve areas for any palpable pulsations or transmitted heart sounds.